Short bones distribute high-magnitude forces. Comparative analysis reveals unique pathological patterns. Developmental dynamics show complex ossification.
Short bones are defined by a compact, cuboidal geometry. They are situated in regions like the wrist and ankle. They absorb high-magnitude compressive forces. They prioritize stability over movement. True short bones are often restricted to carpals and tarsals. Others include the patella due to its high cancellous bone content. Metacarpals are classified as miniature long bones. Short bones have dense, compact bone enclosing a spongy core. The outer surface is covered by a vascular periosteum. Sharpie's fibers anchor it deep into the bone. These fibers are continuous with tendons, establishing a secure interface. Beneath this lies the inner layer responsible. Stripping this envelope deprives the bone of its blood supply, results in localized osteocyte death.
Compact bone contains osteons. Concentric lamellae surround a central canal. Perpendicular Volkmann's canals connect these systems. Within lacunae, osteocytes extend processes. This network allows communication.
The cancellous core is a porous lattice, organized into semilunar packets. Its metabolic activity is 8 times greater, filled with red and yellow bone marrow. Osteogenesis requires systemic nutrients. Vitamin C is essential for collagen synthesis, while vitamin D allows for mineral deposition. Exercise further stimulates this process.
Appendicular short bones originate from the embryonic mesoderm. They develop via endochondral ossification, progressively replacing cartilage with mineralized bone.
Short bones diverge from long bones in growth mechanics. Long bones possess distinct primary and secondary centers, separated by an epiphyseal growth plate. This plate contains distinct zones that drive linear growth. Short bones typically lack epiphyseal growth plates. Instead, they develop from a central primary ossification nucleus and expand in size through radial ossification.
Did you know the capitate is the very first carpal bone to ossify? In both males and females, this occurs between 1 and 6 months of age. It serves as the anchor for the distal carpal row.
The hamate is the second carpal bone to ossify. In females, this occurs from 1 to 7 months, while in males, it takes up to 12 months. Its hook-like process develops later. In females, the trachetrum ossifies between 9 months and 4 years. For males, it typically occurs between 2 to 3 years. It forms the ulnar boundary of the proximal row. The lunate bone is central to the wrist. Ossification occurs from 18 months in females and up to 5.5 years in males.
Let's look at the trapezium bone. It's crucial for thumb mobility. It ossifies between 4 and 8 years, forming a unique saddle joint, enabling complex manual tasks. The trapezoid is a key carpal bone. In both males and females, its primary ossification occurs between 4. It provides a highly stable mid-carpal articulation. Let's look at the scaphoid bone's development. Its primary ossification begins at 4 to 7 years in females, and for males, it takes about 4 to 8 years. It is critical for carpal stability.
Pisiform is the final carpal bone to ossify. In females, this occurs between 8 to 12 years. For males, it typically takes 9 to 14 years. This sequence is heavily influenced by gender-based maturation. The calcaneus is the largest tarsal bone. Primary ossification occurs in the 6th fetal month. The posterior apophysis ossifies later. The talus is a key ankle bone. In both males and females, primary ossification begins at the 6th fetal month. It transmits weight from the tibia and lacks muscular attachments.
Let's review the cuboid bone's ossification. For both sexes, this occurs at 36 to 40 weeks. At birth, it indicates full-term maturity. Let's look at the lateral cuneiform. It's the first cuneiform to ossify. In females, this occurs at 3 to 4 months, while in males, it takes 5 to 6 months. It coordinates midfoot force, a key sequence in development. The medial cuneiform is a key bone in the human foot. In females, ossification occurs around 9 years. For males, it takes about 4 the arch and can develop from 2 centers.
Let's explore the intermediate cuneiform. It's wedged between the medial and lateral cuneiforms. It serves as a highly rigid midfoot anchor. In females, ossification begins around 2 to 9 years.
Let's look at the navicular bone. Ossification begins at 2 to 5 years in females and around 4 years in males. It is highly susceptible to compression.
This bone geometry resists massive force. Notice the high cross-sectional area. Viscoelasticity allows energy absorption, optimized for multi-axial loads. Loading is enhanced by remodeling. Trabecular struts realign to stress trajectories. Osteoblasts deposit new bone matrix, while osteoclasts resorb it. In long bones, this remodeling results in highly anisotropic patterns. In short bones, multidirectional loading promotes a more isotropic in load directions. Short bones act as crucial shock absorbers.
During impact, ground reaction forces can exceed 250% of body weight.
Short bones dissipate this energy through microscopic, reversible deformation.
The posterior tibialis tendon contracts, driving subtalar supination. This causes the CC and TN joint axes to converge, locking the midfoot. The foot becomes a rigid lever. Carpal short bones have unique constraints. Their compact size and extensive articular surfaces limit them highly vulnerable to injury, leading to severe mechanical and vascular pathology. The scaphoid bridges the carpal rows. Falls can fracture the narrow scaphoid waist. This disrupts its unique retrograde blood supply, leading to avascular necrosis. A fracture across the scaphoid waist disrupts retrograde flow. Deprived of perfusion, undergoes necrosis. In rare cases, this occurs without a fracture. This condition is known as Preiser's disease.
Radiographs appear normal. However, an MRI will show early osteonecrotic signal changes. Primary management strategies focus on immobilization, activity modification, and NSAIDs. For Herbert Lanzetta Stage 2, look for increased density in the proximal pole. Primary management involves curettage or non-vascularized bone grafting. Herbert Lanzetta Stage 4. It shows carpal collapse and widespread osteoarthritis. Management includes a proximal row carpectomy or a four-corner fusion.
Kienbach's disease affects the lunate bone. Avascular necrosis causes the bone to die. Risks include vascular and mechanical factors.
The lunate's arterial supply is highly variable, showcasing Y, X, or I-shaped patterns. Microfractures can obstruct venous elevating pressure. This triggers necrosis.
Negative ulnar variance. This shifts excessive mechanical load onto the lunate, producing subchondral microfractures, culminating in lunate collapse and secondary arthritis.
Additionally, lunate morphology influences disease progression. A type I lunate has a single articulation with the capitate. Progression is staged clinically using the pisiform presents a classification challenge. It has only a single flat articular facet. It is embedded within the flexor carpi ulnaris tendon. Biomechanically, it acts as a lever. Trapeziometacarpal osteoarthritis affects the base of the thumb. This unique saddle joint allows a wide range of motion. However, this mobility sacrifices stability.
This joint relies heavily on its stabilizers. Chronic laxity leads to subluxation. This concentrates stress on the cartilage. Over time, this causes severe wear. As the first metacarpal base subluxates, tension fixes the shaft in adduction. The MP joint hyperextends, creating a Z deformity. Eaton-Littler Stage 1 is characterized by slight joint widening and less than 1/3 subluxation. Interventions include splints, NSAIDs, and injections. Stage 2 features small osteophytes. They are less than 2 mm, adjacent to the trapezium. Interventions include thumb splinting or a simple trapezial excision.
Stage 3 of the Eaton-Littler classification is defined by osteophytes larger than 2 mm. Interventions include an LRTI procedure or orthodesis. Treatment depends on patient goals.
Stage 4. Advanced joint space obliteration and severe subluxation occur. Look for scaphotrapezial arthritis. Treatment requires a complete trapeziectomy.
Tarsal coalition is a congenital anomaly. It is characterized by the abnormal union of two or more tarsal bones. This fusion can be fibrous, cartilaginous, leading to severe biomechanical dysfunction.
Tarsal coalitions progress from fibrous tissues to a rigid osseous bridge as the skeleton matures. The normal 10 degrees of internal subtalar rotation is lost.
This loss of movement places excessive stress on adjacent joints, leading to talar beaking. To compensate contraction, imaging reveals the ant-nose sign, a key sign of calcaneal coalition.
Lateral radiographs display the C sign. Coronal CT shows the drunken waiter sign. If conservative measures fail, we use the Wild criteria for surgery.
According to the Wild criteria, if the coalition exceeds 50% of the joint, a primary subtalar arthrodesis is recommended to restore correct foot function. Assessing the articular cartilage integrity is key. If the posterior facet is thick and free of arthritis, we proceed directly to surgical resection. According to the Wild et al. Criteria, advanced osteoarthrosis in adjacent joints is key. This shifts the pathway from resection to joint fusion.
According to the Wild et al. Assessment criteria, if hindfoot valgus is less than 16 degrees, the primary surgical pathway is isolation resection of the coalition bridge.
According to the Wild et al. Criteria, A valgus equal to or greater than 16 degrees requires resection combined with corrective osteotomy and a tendon transfer.
Navicular osteonecrosis presents in two ways: Kohler's disease in kids and Müller-Weiss in adults. Kohler's affects boys aged 3 to 9. It is self-limiting and restores over time.
The tarsal navicular is the last eye. Chronic compression pinches vessels in its watershed zone. High osteogenic potential allows spontaneous repair. Over 3 years, normal size and structure are restored.
Müller-Weiss disease is a progressive osteonecrosis. It leads to structural collapse of the navicular bone. Uneven forces concentrate stress, flattening the lateral half of the bone. Localized overload causes plastic deformation. This results in lateral collapse. Short bones are prone to their structure. Long bones are surrounded by large skeletal muscle groups.
Nutrient vessels enter through limited corridors. This makes short bones highly susceptible to vascular compromise, increasing the rate of bone resorption, leading to structural failure or non-union.
Short bones have a dense shell and a spongy core. This grid absorbs multidirectional loads. Limited blood supply makes them prone to necrosis after trauma. Interventions must focus on preserving blood flow.